I am starting my topic of gynae-obs, that is menopause and hormone replacement therapy, that is HRT. And call that person. Please इधर आइए. उनको बुलाइए. So today's topic is very important in association with gynae topic, because 30% of our ladies, it is not working. So as 30% of our female population is having menopause. So a major portion of women are having, because with the increase in the life expectancy, ladies are entering into menopause, and menopause passing life with the menopause. And the 30% of the women are having this. So we have to look into these ladies, their problems, their lives, and their any management or therapy that improves their quality and quantity of life. So what are our learning objectives today? We have to go through the definition of the menopause and HRT, its pathophysiology, its mechanism, how we diagnose and manage hormone replacement therapy, and its side effects, its contraindications. These are the main learning objectives of today's topic. Now, definition. Menopause is cessation of menstruation for after 1 year of last menses. Any woman having cessation of menstruation at the age of menopause, which is usually between 45 to 55, but median age is 51 to 52 years. Having cessation of menstruation, we do not label her as menopause until she has cessation of this menstruation lasting for 12 months or 1 year. After this period of 1 year, we can label this year woman as a case of a menopause. Median age, as I have said, it is between 51 to 52, but 95% of the women having this menopause between 45 to 55. Means between this 10 years of period, if they are having menopause, this is physiological. Before 45, it is not normal, and after 55, it's again not normal. What happens? Actually, there is no estrogen. There is a exhaustion of the all ovarian follicles, resulting in cessation of estrogen. And when there is estrogen finished, then the all system of endocrine system in the female genital tract also finished. How we recognize it? We recognize it by the loss of the menses, and in most women, they have some signs and symptoms which are even not tolerated by these ladies, that menses loss is no more problem for them after having passing a good reproductive life. There is no need of menstruation, but actually the symptoms and the problems which occurs because of the withdrawal of estrogen, leading to some problems like hot flashes, insomnia, breast and or vaginal atrophy, and reduced skin elasticity is one of the very important presentation of the women coming to us having menopause. The second most important and the late sequence or the consequence of the menopause is the osteoporosis and cardiovascular disease. This presents long-term consequences and are more intolerant and less predictable than early signs and symptoms. Because many of the women having hot flashes, insomnia, breast or vaginal atrophy is common, but this osteoporosis is unpredictable. Actually, when the complication of this problem like fracture with osteoporosis and cardiovascular problem, with cardiovascular problem disease resulting from the menopause, when it results in complication, then they come to know that all is because of menopause. Now, another term which we used to listen many times in our obstetrics and gynecological life is the climacteric and perimenopause. It's a transition phase from fertility to infertility, and it occurs between 45 to 55 years of age. Those who are having menopause at 50 years, then for the last previous 5 years can have this climacteric or perimenopausal symptoms. So this 10 years of the period when they are actually menstruating but having problems because of the coming cessation of menstruation. Associated with signs and symptoms and metabolic adjustment, the major cause of which is major reduction in circulating estrogen level. So what is happening in this period? Though they are menstruating, but the level of the estrogen in the circulation is continuously decreasing and resulting in signs and symptoms and metabolic problems, which are due to adjustment of this decreased or reduced estrogen level in the body and resulting in climacteric or perimenopausal problems. So it's a life from time of onset of ovarian dysfunction until 1 year after last menstrual period. And it's associated with endocrine changes in the body. What are those endocrine changes? We do know that there is a continuous neuroendocrine complex that is leading to our whole endocrine life. What is happening in the hypothalamus? In the hypothalamus, there is the release of gonadotrophin releasing hormones. And there are receptors for the GnRH, that is gonadotrophin releasing hormones, on the pituitary. But when they act on the pituitary release follicle stimulating hormone and luteinizing hormone, which are called gonadotrophins from the pituitary. These gonadotrophins, they act on the ovaries, and ovary results in production of two types of hormones. One are peptide hormones. Peptide hormone include inhibin B, which is released from the ovarian follicles, and ovarian steroids, which are estrogen, progesterone, and testosterone. So, menopause. Now, come to the conclusion. What is menopause? Menopause is the woman which has been in the period of menopause for the last 1 year, and now she is developing signs and symptoms associated with reduced estrogen level in the circulation. And finally, with the menopause, absent or no estrogen in the body. What are the causes of this menopause? These are physiological, these are non-physiological. Physiological are normal menopause at between the age of 45 to 55 is physiological menopause. But in the reproductive life, before this also occurs. That is during lactation, because of the action of the hormones from the prolactin hormone, resulting in menopause, like menopause. No menopause, but it is follicle cessation of menstruation. And the second is the pregnancy. Again, for a 9 months of period, there is no menstruation. It is again a period of menopause, that is cessation of menstruation. But again, it's part of life. Non-physiological causes. Non-physiological again divided into medical causes and surgical causes. Medical causes. Medical include suppression of ovarian steroidogenesis, like those are the drugs which are GnRH analogs. GnRH analogs are the drugs which are analogs of GnRH, which is from the hypothalamus. So when we are giving drugs like insulin and buserelin, these are the drugs, when given continuously, they act on the pituitary. GnRH from the hypothalamus, they act on the pituitary and they cause suppression of the receptors of the pituitary, because of continuous supply of energy. So the receptors on the pituitary gets suppressed and it results in down regulation of the pituitary, and pituitary do not now responding to GnRH analogs. When it is not responding, that is, there is down regulation, it results in failure in the release pituitary hormones, that gonadotropins, results in decreased luteinizing hormones, decreased follicle stimulating hormones, and this period is called pseudo-menopause. That is, we have created menopause but artificially by giving a drug which is GnRH analog, and that acts continuously on the pituitary and finally results in no more hormones from the pituitary, no more hormones from the pituitary and their action on the ovary, and no more hormones from the ovary. So this can cause non-physical medical reason of the menopause, which is called pseudomenopause. Some of the drugs like chemotherapeutic agents for the treatment of some cancers, they also suppress ovaries. They suppress their functions, and there is no release of estrogen, progesterone, testosterone, decreased inhibin B, and results in menopause. That is no menstruation. The second cause of non-physiological reasons of the menopause is surgical. That is, surgical removal of the ovary. And again, a very reason of non-physiological cause of the menopause, though it is a pure menopause, which is like a menopause we are having at the age of 45 to 55, but as it is occurring at wrong age, which is not expected, we included it in the physiological cause, but it's actually natural by nature, and the sequence of events in the body are same, but the period in which it is not being expected, it is occurring. So 1% of the women, 1% of the women before the age of 40 years and 0.1% of the women before the age of 30 years develop ovarian insufficiency. Therefore, it is called premature ovarian insufficiency. Previously, the term was premature ovarian failure. Actually, there is a failure in the function of this. But we do now a term has been changed from premature ovarian failure to premature ovarian insufficiency, because sometimes these are the women later in life, because of the resistance to the pituitary gonadal, they come out of their resistance and they start working. So we do not label them as for permanent non-functioning ovaries, because in some of the ladies, we found this is because of the resistance of ovarian follicles to the pituitary gonadotropins. But other reasons are there also, which are, number one is that they have some chromosomal problem. Actually, they present with those which are having this non-physiological menopause before the age of the 30 years can appear to us and can present to us in the gynae OPD as a case of primary amenorrhea. And we found that there are some chromosomal problems. So this dysgenesis of ovaries do not start their function, like Turner syndrome. 45XO. 45XO is one of the commonest reason of the primary amenorrhea, and patient after having some anatomical reason for amenorrhea, this is one of the very common reason of the chromosomal reason of the primary amenorrhea, and this is non-physiological cause of the premature ovarian insufficiency. Then some autoimmune disorders, so the ovaries are not functioning, some enzyme deficiencies, which are responsible for non-functioning of the ovaries. Secondary amenorrhea, which is leading to premature ovarian insufficiency, are chemotherapy, again for some malignancy, even in the ovaries, and we are giving for the safety of, for the life of the patient, we give chemotherapy, and that results in premature ovarian insufficiency. Radiotherapy, or infections like mumps, tuberculosis, malaria, and varicella zoster virus can damage the ovaries, and these are one of the reasons of ovarian insufficiency in a ladies in young age. What is the pathophysiology? How we diagnose a case of a menopause? Menopause, cessation of menstruation for 12 months in an age of a woman of 45 to 55. We do not go into hormonal confirmation, but age is in favor and the period of 12 months has been crossed. We label them as menopause. Only we require to have this confirmation of menopause in those ladies, either those are having premature ovarian insufficiency and those who request us that they are having problems and their problems should be confirmed through the lab investigations. Because having amenorrhea of more than 12 months in an age of a woman of 45 to 55 and the sign of symptoms, which are because of the circulating decreased estrogen, are confirmatory for the menopause. So let's see how we require to confirm it when it is being requested and when it is being required. The serum follicle stimulating hormone is very important hormone, especially in the women with the climacteric phase, because in the climacteric phase they do not have menstruation cessation, but because of the decreased ovarian estrogen, ovarian follicle inhibin B and progesterone, which is because of the less number of the ovarian follicles, is reducing continuously and producing climacteric or the sign and symptoms like menopause. We have to confirm that while having this serum follicle stimulating hormone confirms it. That level is high. Normal level is less than 20 and more than 20, it means is in the range of menopause. But in the climacteric phase, this level is very high, sometimes 80, 90, 100, even more than 100 level of follicle stimulating hormone. But later on, develop menopause, this level decreases and that's high, but not as high as it is in the climacteric phase. What is the reason for very high stimulating hormone in the climacteric phase or in the early part of the menopause? It is because of the struggle of the pituitary to respond as maximum as to decreasing hormones from the ovary. That is inhibin B, actually inhibin B, which is produced by the ovarian follicles and also estrogen and progesterone. When they are less, come because of the less follicles, which are declining continuously with the increasing age, and they are less, so less hormones, follicle stimulating hormone from the pituitary has to get maximum function from these less number of the follicles. They are producing less amount of these hormones. The first part, menopause, and especially in the climacteric phase, that is the period before cessation of menstruation, is very high level of the stimulating hormone. Menstrual cycle, what happens in the climacteric phase? The climacteric gives us the history that her cycles, which are now complete cessation of menstruation, is when in the climacteric phase, though she was having menstruation, but the cycle length is decreasing because whatever the amount being released from the available follicles is not as sufficient to take the cycle up till the normal 28 or 30 days cycle, but the cycles are decreasing in length, short cycles, because of the less amount of hormones and the withdrawal early, and the cycles are short. So they comes to us in the climacteric phase with the complaint of short cycles. And finally, when the whole of ovarian follicles finished, then there is a cessation of ovulation and cessation of menstruation. Then those are the ladies which are obese. We know that the obesity or the fat adipose tissues have their role in conversion of estrogen to estradiol level. And so when there is a more obesity, there is a more collection of the hormones, adipose tissue not coming out, and then resulting in more serious effects of estrogen deficiency. So some of the features are responsible for more clinical symptoms of menopause, as we found that some of the ladies have their climacteric phase and the menopause phase very silently and very smoothly, but some of them have very disturbing this phase of life. So obesity increases the risk of hot flashes, cardiovascular diseases. Again, those who are having obesity, which is again a risk factor for the cardiovascular disease, when the obesity along with the cessation of hormones, estrogen, because estrogen is a good supporter of the cardiovascular system. So both leads to the problems in the cardiovascular system. Again, it is responsible for increased risk of breast carcinoma, endometrial carcinoma, and also because of osteoporosis, there is a risk of fractures, and because of the cardiovascular atherosclerosis, increased risk of atheroma and stroke. So what happens? Those who have developed menopause, now they are coming to us with the cessation of menstruation from 0 to 5 years. 0 to 5 years can include that 1 year period of when we are actually observing that this period will continue or will she have menstruation. If this 1 year period of 12 months period, when it is occurring, then the signs and symptoms of sudden cessation of the hormones of estrogen, progesterone, and inhibin B, there is especially these symptoms like hot flashes are very high. What is hot flashes? Hot flashes are actually feeling of very hot. There is a red whole body, especially the face, whole body has become red and like an inflammation, and patients feel very hot, very uncomfortable, sweating, and even disturbing the sleep of the patient, because these are the patients they have, especially they are in the mid of the night. And the middle of the night, they wake up because of the sweating and the hot flashing. What happened? Reason is this: loss of modulating effect of the estrogen on serotonergic receptors within the thermoregulatory system of the center of the brain. There are receptors in the brain, in the center of the brain is a thermoregulatory system. This system has receptors which are serotonergic receptors on which estrogen has effect of modulation. That is, it controls this system. But when there is no estrogen, there is an exaggerated response of this thermoregulatory system to peripheral minor temperature changes, exaggerated response to the minor temperature changes because and resulting in so much peripheral vasodilatation that results in hot flashes, red face, and sweating because of the slight change of the temperature and exaggerated response of the peripheral vasodilator system. This results in night sweats. Hot flashes at night makes the person to fully wake up when sweating, so patient have insomnia, loss of sleep, disturbed sleep, exhausted, tired, complain of poor performance during daytime because decreased comfortable sleep at night. So this disturbs very much their quality of life. And those which are having again obesity, that is high BMI, their vasomotor symptoms are more worse than those who are having low or normal BMI. There is a continuous breast atrophy in this period, that is 0 to 5 years of life, and there is a loss of elasticity of the skin, and these changes makes the person with the development of aging changes. How many percent of the women, those who develop hot flashes? About 75% of the women develop hot flashes in the first 5 years of their menopausal life. And this results especially insomnia, sleep deprivation, disturbance in the quality of life, and so they are disturbed, they are very angry, they have a desire to fight with others, so their mood changes, their behavior changes are also very disturbed because only one reason, which is the hot flashes and night sweatings. Then what happens in the later part from 3rd year of the menopause till the 10 years of the menopause? There are changes in the urogenital tract. There are changes in the vaginal mucosa, which becomes very dry. This vaginal mucosa dryness results in peeling of the skin of dry mucosa, damage to the small vessels, and results in irregular spotting, dyspareunia, again because of this dryness of the vagina, recurrent urinary tract infections, and hormonal deprivation also leads to uterovaginal prolapse. What are the psychological causes? Mood changes, anxiety, loss of short-term memory, lack of concentration, loss of self-confidence, depression, decreased libido. Because of this hot flashes, because of dry vagina, and because of this loss of sleep and insomnia. So after 10 years, long-term consequences of menopause. Osteoporosis. Osteoporosis is defined as it's a compromised bone strength predisposing to the fractures because of the loss of the estrogenic support for the skeletal mechanism. We know that estrogen has a very important role in the repair or in the continuous strength of the bone. It maintains the repair. It maintains the repair of the skeletal system, because we know that continuous formation and decay or continuous loss of skeletal strength and then again formation of this skeletal system is part of life. And this formation and loss is mainly supported by estrogen. So this loss of estrogen actually results in loss of support to the skeletal metabolism. Some have very high risk factors, like those who are having family history of osteoporosis, those who are smokers, those who are premature ovarian insufficiency. premature ovarian insufficiency, as it is occurring in the very small, early part of life. So it's a long period. These women has to go through this menopause and to have this osteoporosis with its worst form. And the other risk factors are those who are immobile, like those who develop weakness because of the fractures, those who have developed weakness because of the cerebrovascular accidents, and immobility because of the cardiovascular diseases, risk of fractures. Liver disease, again, why liver disease? Liver disease, actually, again, the estrogen has a fact on the steroid, and the coagulation factors are from the liver, and they result in a problem with the enzymes and the skeletal problems. Steroid use, thyroid and parathyroid disease. Actually, we consider the estrogen as a antagonist of parathyroid hormone. Parathyroid hormone is causing release of calcium from the bones, making the bones weak, but estrogen causes reformation of the bones, that is resulting in more strength of the bones. So it is antagonist of the parathyroid hormones. Thyroid hormones is also responsible by increasing metabolism, and the metabolism results in overfunctioning and the release of calcium. Then the long term, that is more than 10 years, symptoms also include cardiovascular diseases and dementia. Dementia because of the neuropathy, which they people also have developed in good time. Now, we know that bone changes increases during childhood and reaches at peak between 20 to 30 years. In women, bone decline begins at 30 and accelerates at menopause. The most rapid bone loss occurs in the first 3 to 4 years of menopause. So, maximum peak we receive when the bone formation is continuous and in a good form is between 20 to 30 years. Then little decline, and which accelerates at menopause. And in the menopause, first 3 to 4 years, this bone loss is very high. Bone loss occurs more quickly in the smokers and thin bone. The most common site of osteoporosis related fracture is the vertebral body, proximal femur, humerus, ribs, and distal. And the men to women ratio is 1 to 4. Actually, women are having 4 times more chance of fractures as compared to men. So, what is osteoporosis, which is because of estrogen, is actually a skeletal disorder characterized by compromised bone strength, predisposing to an increased risk of fracture. Women to men ratio is 4:1. What is the role of the estrogen? Estrogen acts as a physiological restaurant on bone turnover and balances bone turnover and formation. So bone turnover and bone formation is in balance with the help of estrogen. It appears to antagonize the effects of parathyroid hormones, as I have already told you, on calcium metabolism. Now, after 10 years, 2 main symptoms we have found. One is the osteoporosis, which we have discussed in detail, and now the second is the cardiovascular changes. Cardiovascular changes are that in the vessels of human are presence of estrogen receptors. That is, blood vessels are with estrogen receptors. So that when there is a decreased oxygen, there is a clinically reduced vascular resistance. And this oxygen is resulting in decreased vascular resistance and resulting in more blood flow. But with the estrogen withdrawal, this flow, that is, there is an increase in the vascular resistance and decrease in the blood flow that results in risk of the myocardial infarction. So, Estrogen is responsible for the good flow through the circulation because of the presence of estrogen receptors on the blood vessels, and this results in clinically reduced vascular resistance. But with the absence of the estrogen, vascular resistance a little increases and leads to decreased flow, which can cause myocardial infarction. This can cause cardiovascular accident, and these are responsible due to the estrogen. Another effect of the estrogen is the more effect on the total system of the lipid profile, which is more towards atherogenesis. So, estrogen actually reduces the atherogenesis throughout the body. But when there is insufficient or absent estrogen, the system of atherogenesis becomes more active. What happens? Estrogen causes it decrease in cholesterol level, increases the high density lipoproteins, which are protective lipid, and decreases the low density lipoprotein. But when estrogen is decreased, total cholesterol level increases, high density lipoproteins decreases, low density lipoproteins increases, and there is no significant change in the triglyceride. So these are three main things which are disturbed from the estrogen. That is, total cholesterol increases, high density lipoprotein decreases, low density lipoprotein increases, and these are more conductive towards atherogenesis. Mainly clinical, and according to symptoms like menstrual irregularity, how we diagnose? So only the things: FSH is more than 30, reduced serum estradiol, reduced serum inhibin B. In the climacteric and the perimenopause phase, there is a menstrual irregularity because of insufficient amount of hormones. There is a short cycles. There are early spotting, amenorrhea, when the whole system is cessation, and vasomotor symptoms because of the effect of the estrogen on the thermoregulatory system. How we manage them? Because as I have already discussed, that there is a major contribution of women is with the menopause. So we have to see into their lives. We have to assess their problems of life. What problem, like hot flashes, like temperature changes, insomnia, irregularity of menstruation, what problem they are having to improve their life quality. Then we have to tell them they should have exercise, but at a normal level, because they are at risk of fractures also. They improve their nutrition, they improve their calcium, they improve their vitamin D, so that they have more strong bones, which is being at vulnerable level as there is less estrogen. They should avoid smoking, they should avoid alcohol, and we should assess their sexual history, whether they are having dyspareunia, dryness of vagina, itching in the vagina, irregular spotting, and when they are having perimenopausal level, when they are having menstruation, whether they should practice contraception to avoid pregnancy or do not. So need of contraception should also be discussed for the menopausal, for perimenopausal lady, and for those who are in the first year of menopause when the menopause has not been confirmed. We should take their obstetrical history. Drug history is also very important, because like GnRH analogs, if they are on these drugs, which producing pseudomenopause, should also be dig out through the history. Age of menopause, again, we know that 45 to 55 is the normal age, but there is a premature ovarian insufficiency, and with those which are with the premature ovarian insufficiency, along with having problem with their reproductive life, they also have more early signs and symptoms, more severe aggressive signs and symptoms of menopause, and at more risk of cardiovascular disease and osteoporosis. History of cancer is very important because if we are going to give them for their problems, hormones, then these ladies, we should clearly exclude family history of breast cancer, endometrial cancer, ovarian cancer. Chronic illnesses which are responsible for osteoporosis, renal functions, and cardiovascular disease. Whether they are taking steroid, because when they are taking steroid, they are at more risk. And those who are having history of fractures, to avoid future fractures, we should look into them and how to help them. Family history, again, very important, like cardiac disease, osteoporosis disease, Alzheimer's disease, dementia, and the psychological problems are more strong in the women with a family history of Alzheimer's, neurodegenerative disease, and thromboembolic disease. Thromboembolic is again because we know that estrogen deficiency is associated with atherogenesis. Then we have to examine for breast atrophy, for skin changes, for BMI. BMI is very important, as we know that all osteoporosis and cardiovascular disease are more in those which are with high BMI. Their blood pressure should be examined, baseline investigations, detailed systemic examination to exclude the presence of estrogen-dependent tumors in the breast or the pelvis. Because if we are going to give them drugs which are estrogen, so these are not the candidates for these drugs. Vaginal assessment and the cervical smear. We know that cervical smear we should perform till the age of 60 years. So menopause and absence of menstruation is not the reason not to take cervical smear. It should be started from the reproductive period of life till the 60 years of age, and menopause age can be included in the cervical smear. Now, how we help them out? By hormonal replacement therapy. Patients should be examined and counseled on the individual nature of the problem. For example, if those are having hot flashes, then we have to concentrate on managing their hot flashes. Those who are having mood changes, those who are having some vaginal dryness, then so that local treatment, local application of the drug, if fulfilling their problems, then we do not go into the systemic drugs. So have a problem with those who are at risk of developing cancers, those who are at risk of developing hormone related problems. So we give them hormone replacement therapy when the presence of symptoms interfere with their personal, mental, and professional life. History, including any past medical and surgical intervention, is also very necessary. For example, those who are having early surgical removal of the ovaries. Gynae history to rule out problems like fibroid, endometriosis, breast disease, especially breast benign disease in the past, can be reflourished with the hormone replacement therapy. And the malignant breast disease, of course, very important. So first of all, we can go into non-hormonal approach by giving, if they are having some skin problem, if they are having pain and weakness, acupuncture, herbal preparations are available like cohosh, evening primrose, ginseng, non-hormonal therapy like phytoestrogens, like isoflavones. These are achieved through the red cloves, natural progesterone gel, and dihydroepiandrosterone acetate. These are the natural hormones which are available, and these are called phytoestrogens. and they are like estrogen, and they can be given for the treatment of estrogen deficiency. Non-hormonal treatment for the vasomotor system like alpha adrenergic agonists like clonidine, beta blockers like propranolol, and modulators of central neurotransmission like fluoxetine, gabapentin, venlafaxine. These are the modulator of central neurotransmission, and then they have a role on the vasomotor symptoms, hot flashes. If they have tachycardia, they have feeling of ghabrahat, then beta blockers and alpha receptor agonists. Hormonal treatment: estrogen, progesterone, both can be given. Main thing is estrogen. Estrogen acts by inhibiting the gonadotrophins by the hypothalamic pituitary system. We know that this is actually a feedback from the gonadotrophins that resulting in more and more follicle stimulating and hormones and luteinizing hormones. So only estrogen can be given and combination therapy can be given. The route can be oral, the route can be transdermal, the route can be subcutaneous, and route can be local. For example, vaginal creams are available, estrogen creams are available. These are applying the vagina locally. Some cutaneous devices are available, which we implant, and transdermal patches are available, estrogen patches that can be given, and the drugs can be taken orally, like estradiol valerate, conjugated active estrogen, and estrogen. These are the drugs available for oral use. Systemic estrogen only hormone therapy is suitable for the women who have had a hysterectomy, as unopposed estrogen results in endometrial hyperplasia and endometrial cancers may develop. So those ladies with intact uterus, we have to avoid only estrogen with systemic therapy, because those which are having the hysterectomy, that is no uterus, then we can give them only estrogen therapy, because there will be no endometrial hyperplasia and risk of endometrial cancer because of unopposed estrogen, which should be balanced with the progesterone in cases of intact uterus. What are the side effects of estrogen? Breast tenderness or swelling, nausea, leg cramps, and headache. Progesterone can be given cyclically or in the form of continuous combined regimens, usually given cyclically in preparative over 28 diet cycles. Of those, now, those who are with the intact uterus, we cannot give them only estrogen systemic therapy. We have to combine this therapy with the progesterone. Either cyclically, that is, for example, in the 28-day cycle, in the first 16 to 18 days, we give only estrogen, and in the last 10 to 12 days, we add progesterone also. So, in the first 15 to 16 days, we are having estrogen only, and in the last 10 to 12 days, we are having both estrogen and progesterone. So, results in regular menstrual cycle, and these are the drugs. When we give them, we have less risk of endometrial CA, as we are not giving them unopposed estrogen. Can also be given as continuous combined therapy, that is, continuously both estrogen and progesterone in a drug, which we give them continuously, and there is both estrogen and progesterone effect on the uterus, and 90% of these women have no withdrawal bleeding, because we are not stopping the drug by giving them progesterone in the last 10 days and estrogen in the first 6 to 18 days. We are continuously giving both estrogen and progesterone. So 90% of these ladies are amenorrheic, and this is very good for them, because they do not want, after having menopause, they do not want to have menstruation, so that they can have more proper their religious performance and not disturbed by withdrawal bleeding. One of the continuous combined therapy, which is synthetic steroid, exhibiting both estrogen and even androgenic activity, are available in the drug Tibolon. Tibolon is a drug which is synthetic drug having all these hormones, and then when they are given, they are continuously acting on the uterus mucosa, and in 90%, these are the ladies, are free of symptoms without menstruation. These testosterone or androgens are the drugs for the sexual desire problem, disorders of sexual problems, dryness of vagina, and failure to have a sexual desire. They require androgens in the form of testosterone. But nowadays, no more testosterone drugs are available, and these are now more in use. What are the side effects associated with progesterone? Progesterone can cause fluid retention, breast tenderness, headache, mood changes, depression, and acne. How we follow them? We follow them. Those who are on hormone replacement therapy, they should be followed. First year, they followed 3 monthly. In the second year, 6 monthly, and then year. Especially in the 5 years, usually they require this drug because of very disturbing hot flashes. But later on, because of this hot flashes are not very disturbing for them, as we found that with the around after 5 years, the levels of estrogen are not continuously declining. Now they are being maintained, and so that the problems like this are usually less. But again, they are at more risk of having cardiovascular problems and osteoporotic problems. Now, what are the contraindications of the hormone replacement therapy? Absolute contraindications are suspected or present pregnancy, suspicion of breast cancer, endometrial cancer, acute liver disorders, because these are the hormones, they have to be metabolized in the liver, and if there is a liver problem, then we should not give that. Uncontrolled hypertension, confirmed venous thromboembolism, because we know that if there is a thromboembolic phenomena before, giving them this hormone replacement therapy exaggerate the problems of venous thromboembolism. Non-thrombophilia, that is deficiency of protein C, S, and antithrombin 3, and factor 5 laden, they result in thrombophilia. And we know that with the thrombophilia, hormone replacement therapy or oral contraceptives, these are contraindicated. Autosclerosis, that is ear problem, which is again not given. What are the relative contraindications? Uninvestigated abnormal uterine bleeding, uterine fibroid, past history of benign breast disease, unconfirmed venous thromboembolism, chronic liver disease, but here acute liver disease. Contraindications for absolute contraindication are acute liver disease, and relative is chronic liver disease. And those who are having migraine also have a relative contraindication, not absolute. Thank you very much. Now you can ask question.
जी मैडम.
Yes, one of the question is, what do you mean by short cycle? Does it refer to reduced number of bleeding days or decrease in the number of complete cycles? Decrease in the number of the cycles means more in the number of the cycles. Short cycle means because of the less amount of hormones, the withdrawal occurs earlier rather than keeping the endometrium for a long period by the high amount of hormones. They take first phase by the estrogen, the last phase, that is last 10 days or 14 days, 12 to 14 days with the progesterone. Usually first phase of the cycle is not fixed. Second phase of the cycle, we know that of the menstruation is fixed because of the progesterone. But when the hormones are less, estrogen is less, the first phase of the cycle is getting shorter. Means estrogen finished by 8 to 10 days, and then fixed the progesterone, and then early menstruation. Short cycles means more cycles, means frequent cycles. How we follow the cycles? First year 3 monthly, second year 6 monthly, and in the third year from onward yearly. How does it? We know that estrogen has effect on vessels, that is, it has a receptors on vessels, as well as it is having atherogenesis effect. So when there is deficiency of estrogen because of increase in total cholesterol, decrease in high density lipoproteins, increase in low density lipoproteins. And these atherosclerosis can lead to venous thromboembolism and lead to myocardial infarction. Okay. While on the other hand, if we give it in the form of combined oral contraceptive, it can lead to venous thromboembolism. Yes, this venous thromboembolism can lead to myocardial infarction. What were the non-hormonal treatments of vasomotor symptoms like hot flashes? First of all, hot flashes are associated with feeling of tachycardia. Only ladies are coming to us. They are saying that they have tachycardia, but some are with the hot flashes also. And for the tachycardia, simple beta blockers, propranolol, and alpha agonist can decrease their vasomotor response of tachycardia. But for the hot flashes, we require non-hormonal drugs like isoflavins. These are the isoflavins are actually estrogen-like drugs. These are naturally occurring, and we can find them from cloves and other things. And when we give them isoflavins, they can have reduce in the vasomotor symptom, and the other are the neurotransmitters. Neurotransmitters can also decrease their feeling of this hot flashes, their irritability, their anger, and so they feel good. Anything else? So should we finish?
Okay, madam.
I am finishing. Thank you, all of you.
Okay, madam. Allah Hafiz. Take care.